All right, guys. I'm going to finish up the last few slides here on our urinary system lecture. We've been working our way through the renal tubule. Remember the renal tubule. I'm balancing back here to our picture of the nephron. Renal tubule is going to be receiving that filtrate from the glomerular capsule or renal corpuscle, where the water and small stuff from our blade is able to escape, forming into filtrate, which then flows through and first to our proximal convoluted tubule, and we return a good majority of the water right away in this proximal convoluted tubule, performing what we call tubular reabsorption. What's not returned to the blood, still in the tubule, will travel down into the renal medulla by way of the hairpin loop known as the loop of Finlay or nephron loop, descending down and then going back up. We are performing what's called the countercurrent multiplier mechanism here, and that's what we finished up talking about last time, where we're pulling out water from the descending limb, which is capable of doing so because it's permeable to water, and that's because it's more thin than the thicker ascending limb, which is responsible for pumping out salt, which is what draws that water out from the descending limb. So we call that countercurrent multiplier mechanism, because what's happening here in the ascending limb is contributing to what's happening here in the descending limb. What we're going to do now is move on to our final segment of the nephron, what we call the distal convoluted tubule, and then we'll talk about the collecting duct, which is where we finalize the formation of that urine from the filtrate. So reading through, since salt is pumped out of the filtrate in the ascending loop, the ascending limb of the loop of Finlay, the fluid in the DCT, distal convoluted tubule, becomes very hypotonic. Hypo, remember, means low. So this would be a lot less salty. Like hypertonic would be like salt water. This would be like the opposite of that. The interstitial space of the renal medulla is very hypertonic. That would be like that, salty water. This helps form the osmotic drive for the reabsorption of water across the walls of the collecting ducts, allowing for some water conservation. And that really relates to what we were talking about there at this slide, or in this figure, when we were talking about that countercurrent multiplier mechanism. You know, the collecting duct is right here, right next to the ascending limb. And we can see right in here in our figure, we're pulling out water here just like we were over here. And the collecting duct allows for us to pull out any remaining water just before we finalize it and form it into urine, form that filtrate into urine. Okay. And it's because that, once again, the interstitial fluid, the interstitial space in the renal medulla is super salty because of the sodium chloride, the salt that's being pumped out by that ascending limb. So the fluid here is hypotonic, the fluid out here is hypertonic, and water is always going to go from low to high solute concentration. And so that's what this first couple of sentences is all about. Within our distal convoluted tubule and our collecting duct, we have principal cells that carry receptors for the specific hormones that regulate the amount of water and salts that are reabsorbed. And we've talked about some of these hormones already here in this lecture. The first several we've talked about. Angiotensin 2, we learned earlier in the lecture, reduces GFR, glomerular filtrate, so it reduces that fluid that's pulled out of the blood. But it also enhances the reabsorption of salt and water in the proximal convoluted tubule, and triggers the release of aldosterone. Remember, we call this whole situation where angiotensin 2 is involved, what we call the renin-angiotensin aldosterone mechanism. Aldosterone, as we learned early in the semester, is nicknamed the salt-retaining hormone, secreted by the adrenal cortex when our sodium levels fall or our potassium levels rise. It causes the retention or the reabsorption of sodium chloride and water, which chases after that salt, reducing urine volume and raising blood pressure. So this helps promote the return of water to the body along with the salt. And so these two are going to promote both water and salt being returned back to the blood. Antidiuretic hormone secreted by the posterior lobe of our pituitary when we're dehydrated and when our blood osmolarity levels are high, basically meaning that we are low in water levels. It's stimulated to be released by osmoreceptor neurons in the hypothalamus. When an increase in plasma molarity increases, like in dehydration, it promotes water reabsorption. Okay, so these first three are going to promote dumping water back out of the tubule into the bloodstream. The fourth hormone we talked about earlier in the lecture is the only one that we said increased GFR. Okay, it's released by the atriomyocardium of the heart in response to preload or filling pressures. Basically, when our blood volume is too high because we have too much water in our body. So this is the only one that's going to promote us to excrete more salt and water in our urine, thus reducing our blood volume and our blood pressure. Okay, so this is the only one that's going to try to make us pee out more water and pee out more salt. Now, the last hormone listed here has nothing to do with water or salt reabsorption or secretion. Parathyroid hormone, we learned earlier in the semester, released by the parathyroid gland, helps regulate our calcium levels. It's released when our blood calcium is low, what we call hypocalcemia, and it promotes the reabsorption of calcium. So it helps us return calcium to the blood. So that is our hormones that help regulate, as it says here on the next page, tubular reabsorption and tubular secretion. And this is just giving you the exact same information, gives it a little bit more details than I did, but same meat and potatoes is there. All right, this next slide here is just kind of a breakdown on what's kind of taking place at various points throughout the nephron, starting up here in the renal corpuscle where we're first forming glomerular filtrate. We talked about pulling out all the water and solutes from the blood and filtering it down to the proximal convoluted tubule. We didn't really talk much about secretion in the PCT. We talked a lot more about reabsorption. It breaks it down a lot more in detail than we did. They talk here in the nephron loop kind of about some other stuff as well. We kind of really focused in on water, salt, sodium and chloride, and urea. Then into the distal convoluted tubule and the collecting duct, you can see all the things that are being reabsorbed or secreted, which, like I said, this kind of just goes into way more detail than we did. Could have got into a lot more detail about, all the different ions and that kind of stuff, whether they're being absorbed, reabsorbed, secreted, etc. But I didn't, because that's quite a bit of information that I would be requiring you to know. So at this point, we've formed our urine and we're ready to talk about what happens to it next. Okay. From our kidneys, the renal pelvis within the kidney will funnel our urine into our ureters. Each ureter is a muscular tube, passes dorsal or posterior behind the bladder, actually enters and fills it from below. The bladder itself is a muscular sac that's found on the floor of our pelvic cavity. It's inferior to the peritoneum and posterior to the pubic symphysis. That's all anatomy-based stuff. But it is going to hold that urine until it's timely to go. When it is a timely situation to go, the muscular layer, the middle layer of it, called the detrusor muscle, will help compress and push that urine down into what's called the urethra. Okay. At the floor of the urethra, there are two openings from the ureters. We call these urethral openings, and then an opening that leads to urethra, what's called the internal urethral orifice. They create a smooth surface triangular area. This is called the trizone. Like I said, it's on the bladder floor and happens to be a common site of bladder infection. The urethra itself, kind of like the ureters, is just a tube that's going to carry the urine, in this case, out of the body, a process that we will call micturition. We're going to talk about here on the next page. Guarding the urethra are two sphincters, kind of like what we talked about with the anal sphincters. There's an internal, there's an external. The internal is involuntarily controlled, and it might not be a bad idea, put in parentheses here. It's made up of smooth muscle. The external urethral sphincter is made up of, or is under voluntary control, and it might not be a bad idea to write down that it is made up of skeletal muscle. So internal IN, involuntary IN. It's probably the easiest way to kind of talk about them, or remember it, I should say. Looking at the figures at the bottom of the page, we see a sagittal section of a male on the left, a female on the right. And as you guys can see, there's some big differences. Aside from the reproductive structures that we'll get into, like the vagina and the penis here in our next lecture, one thing to know is that the urethra in a male is a shared structure. It carries urine, but it also carries semen. So it's part reproductive, part urinary function, whereas the urethra in a female, very short, only carries urine, completely separate structure from her reproductive structure known as the vagina. So we'll kind of talk about the urethra again in our next lecture. When it comes to men, there's actually 3 parts to the male urethra. You can see those are labeled there in the picture. And we'll be talking about, how like the prostate interacts with the urethra along with other fluids that are secreted when a male ejaculates. Nice little box down there at the bottom. That's more anatomy-based stuff, but it kind of gives you some details about how the male urethra and the female urethra are different. Not something I'm, specifically wanting you to know, but I included it anyway. Okay, on to what we call micturition, fancy word for peeing or urinating, partially controlled by what we call a spinal micturition reflex, where the reflex center is found in the sacral regions of our spinal cord. So this is a spinal reflex. Remember back when we talked about reflexes, we learned that there are cranial reflexes where the integrating centers up in the brain. There's also spinal reflexes where the integrating centers down in the spinal cord. This is an example of one of those spinal reflexes. When the bladder fills up, it activates stretch receptors, resulting in action potentials being sent to the micturition center. That's located in that spinal cord. You can see it's bracketed off down here in the bottom. This reflex activates a couple different things. Parasympathetic neurons that cause contractions of that detrusor muscle that I was talking about, that middle layer of the bladder. Relaxation of the internal urethral sphincter. And at this point, a person is going to have the urge to pee. Okay, they're going to need to pee. They'll feel that. But, and this is all, for a person that's potty trained. So, not a infant or a young toddler. When they gain control over that external urethral orifice, or sphincter, they're able to control it and not allow the urine to come out of their body. And so the signal will come back to that external urethral sphincter, and causing it to contract, and the person will have the urge to urinate but not go. And when that person wants to consciously urinate, the micturition center inhibits somatic motor neurons that innervate that muscle and allow it to relax. Okay, so in order to contract that muscle, we need voluntarily controlled information coming down from our cerebral cortex. And that's what this big line is showing you. But when it's time to pee, we inhibit it, causing that external urethral orifice, or excuse me, I keep saying orifice, that's the opening, the sphincter, to relax. And although emptying of the urinary bladder is a reflex, in early childhood, we learn to initiate it and stop it voluntarily. So it's kind of one of those examples that is, an exception to the rule. We said earlier in the semester, typically reflexes are hard to stop or hard to inhibit. Like we talked about, like touching something hot and you can't help but remove your hand from it, or when you go to the doctor and they hit you on the knee and your leg kicks out. We can't suppress those, but we can actually suppress this one through learned control of our external urethral sphincter muscle and certain muscles of the pelvic floor. Our cerebral cortex can initiate micturition or delay its occurrence, and it's all for a limited period of time. You're not going to be able to hold your urine, hold your pee forever, because eventually, you got to go, because your bladder's not going to be able to continue to expand. Okay, what we're going to do is transition here for our last couple slides is or into acid-base balance. Okay, pH balance. Major homeostatic challenge is to keep our hydrogen ion concentration, or in other words, keep our pH of our body fluids at an appropriate level. Without the maintenance of acid-base balance, normal cellular function wouldn't exist. And that's because it all relates back to what we talked about when we first learned about proteins, that proteins are susceptible and prefer kind of two important things. The temperature to be just right and the pH that they are surrounded by and the fluids to be just right. Otherwise, proteins will denature. Remember, that's where they unwind and lose function, which, thinking back to my slinky analogy, where the slinky, gets twisted or knotted or comes unraveled, it no longer is able to walk down the stairs correctly. Now, we talked about acid-base balance just briefly in our lecture when we first introduced acids and bases back in our biochemistry lecture. We kind of said we would focus in on the pH mainly in this class of our blood. We learned in that lecture that we like to keep our arterial blood pH at about 7.4. So somewhere between 7.35 to 7.45 would be normal. That is slightly basic because if you remember, pH scale 7.0 is neutral. Anything above that is a base, and 7.4 is very close to 7.0. So it's a very, very weak base, but it is a base. The removal of hydrogen ions from our body fluid and its subsequent elimination from our body depends on three major mechanisms: buffer systems, exhalation of CO2, which we just recently talked about in our respiratory lecture, and then what we've talked about here in this lecture is excreting out hydrogen ions using our kidneys and pushing it out in urine. Reading through buffer systems, remember, a buffer is something that can act quickly to temporarily bind to hydrogen ions or and remove them from solution. And that helps raise pH of our body fluids, but actually will not remove the hydrogen ions from the body. So buffers help neutralize, but they're not an effective way of getting hydrogen ions out of the body. A protein buffer system is the most abundant buffer system in our intracellular fluid in our plasma. Amino acids making up these proteins are capable of releasing hydrogen ions when pH rises. These hydrogen ions can then combine with hydroxides, OH negatives, forming water. And the other end of an amino acid is capable of combining with hydrogen ions when pH falls. And that would make our pH go up. Okay. A carbonic acid bicarbonate buffer system is based on our bicarbonate ions, HCO3, that can act as a weak base, and carbonic acid, H2CO3, which can act as an acid. We've talked at pretty great lengths here in the last few weeks about bicarbonate ions, carbonic acid, CO2, water, all that wonderful stuff, how that all is involved. And then the phosphate buffer system utilizes various forms of phosphate ions that help to regulate acid-base balance in our cytosol. In Unit 6, we learned that by changing the amount of carbon dioxide we exhale, either by rapidly breathing or shallowly breathing, we can affect our pH, increasing the rate and depth of breathing. In other words, breathing more rapidly and more deeply results in more carbon dioxide being exhaled, which lowers the level of carbonic acids in our blood, which helps to raise blood pH. Okay, and we have to remember that increases in carbon dioxide concentration in our body result in a drop in pH due to increases in carbonic acid, which is because when CO2 builds up, it combines with water and forms that carbonic acid. Okay? So decreases in carbon dioxide concentrations result in elevations in pH. And we talked about in that lecture hypo and hyperventilation. Hypoventilation would be less rapid, less deep breathing, which means less CO2 is exhaled, which means hydrogen ion concentrations will increase and pH will drop. Okay. Hyperventilation is more rapid, more deep breathing, resulting in more CO2 being exhaled, causing hydrogen ion concentrations to decrease, which causes pH to go up. Okay. This is very important in short-term regulation of our pH or acid-base balance. Using our kidneys to excrete hydrogen ions is much slower, but is the only way to eliminate acids other than carbonic acid. And the acids that are excreted are going to, go out in our urine. And we'll talk a little bit more about that here on this page. Now, unfortunately, it's not always feasible to keep our blood pH right there at 7.4, or at least between 7.35 to 7.45. If it drops below 7.35, so let's say you hit 7.3, we would call this an acidosis. Now that's kind of misleading because 7.3 is not an acid, it's still basic, but you're trending towards 7 and below, so that's why we call it an acidosis. Major effect of this is depression of the central nervous system by way of depressing synaptic transmission. Remember, synapses are where neurons meet. The synaptic cleft is where we release those neurotransmitters like acetylcholine and epinephrine, norepinephrine, all that wonderful stuff we learned about previously. But this can ultimately cause a person to fall into a coma or even possibly lead to death. Alkalosis is the opposite, where blood pH would rise to 7.45 or higher, or I should say above 7.45. Major effect of alkalosis is what we call overexcitability in both the central nervous system and peripheral nerves, causing nerve impulses to be conducted repetitively, even when they're not stimulated. Okay. Excitability, we learned previously back in our lecture on neurons and the nervous system, was the ability of a neuron to respond to a stimulus by creating an action potential. So essentially, overexcitability means that we are repetitively creating action potentials, and it even says there, even when possibly not stimulated. This can cause nervousness, muscle spasms, even convulsions, and death. So both acidosis and alkalosis can be extremely serious. To prevent and to counter these, we perform what's called compensation. There's two forms of compensation: respiratory compensation and renal compensation. So respiratory compensation is going to involve changes in breathing, and this is going to help us involve regulation of our blood PCO2, either by breathing off more CO2 to lower PCO2 or breathing off less CO2, which is going to make our PCO2 go up. An increase in blood PCO2 is going to lower pH, whereas a decrease in blood PCO2 will increase our pH. Over on the right, we are showing respiratory compensation when it looks like we show blood pH is going down. So a decrease in blood pH, or we could say an increase in hydrogen ion concentration, detected by those chemoreceptors that we previously talked about. Signals sent up to our medulla oblongata, where our medullary respiratory center, medullary rhythmicity center is located. The nerve signal comes back down to our effectors, which are our respiratory muscles that make us breathe more frequently and forcefully, causing more CO2 to be exhaled and returning our pH back to normal. Okay. A lot more complicated and a lot more long-term, in effect, is renal compensation, which involves secretion and reabsorption processes that we talked about in this lecture. So either pushing stuff out into the tubule to be lost in urine, or returning them from the tubule, from the tubule back to the blood. Like I said, this is important in long-term acid-base balance, and it helps regulate, or we regulate blood bicarbonate concentration by reducing the rate of bicarb excretion when our pH decreases, and by increasing the rate of bicarbonate excretion when pH increases. Bicarbonate is a base, so if our pH is down, we will retain more bicarbonate because bicarbonate will neutralize the acidity of our blood. And the opposite occurs when our pH is elevated. We don't want more buffers, more bases in the blood, so we will push those bicarbs out into our urine, and that's going to make our pH go back down. Now, our final slide here just talks about couple different things. There's several things going on actually here with this page. At the top we show 4 examples of acidosis, alkalosis, respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. This is a figure that shows what our body will do in response to those different conditions. So what we want in a normal homeostatic situation is to be at point A, where our pH is 7.4, our PCO2 of our blood is 40 millimeters of mercury, and our plasma bicarbonate is around 26 or so millicube per liters. Okay. In a respiratory acidosis state, we are going to go from A to B. So acidosis means that our pH is dropping. Okay. And this is because our PCO2 levels have gone up from 40 to 60. Okay. Now this can occur due to things like, just not being able to breathe deeply and fast enough, like during emphysema, other dysfunctions of the respiratory tract or respiratory system. So if we have a respiratory situation, we're going to compensate using our kidneys. Okay. So we'll go from A to B, but then we'll go to D. And we always want to end back up at 7.4. And so by compensating using our kidneys, what we do is we increase the bicarbonate levels in our blood. We stay at PCO2 of 60, but we raise up our plasma bicarb levels to get our pH back to 7.4. So respiratory acidosis is A, B to D. Respiratory alkalosis is A, C to F. Okay. Respiratory alkalosis is where our pH goes up to 7.6-ish as it shows here. And that's because we're breathing too rapidly, hyperventilating, which can occur like when somebody's going through severe anxiety. And you hear about that all the time. You see it in movies. People have to breathe in a bag. And there's a reason why, because that's going to drive their PCO2 levels back up. But if they don't have that option, what they can do is use their kidneys to compensate, bringing their blood pH back to 7.4. And this is done by decreasing the excretion of hydroions and decreasing the reabsorption of bicarb. So getting rid of more bicarbonate from the blood, meaning it's lost in our urine. Bicarb levels go down here in our graph. We return back to 7.4. Metabolic acidosis, metabolic alkalosis. Let's talk acidosis. Acidosis, we go from A to G. Okay, A to G means that we're not changing PCO2, but what's happening is bicarbonate levels have gone way down. So we compensate by going to F, getting back to 7.4. And so let's read through. Metabolic acidosis can occur due to decreased bicarbonate, causing decreases in pH. And this can be like what happens when somebody has diarrhea, or they've accumulated acids like in ketosis, or their kidneys are not functioning correctly. Okay. By going from G to F, we go from PCO2 of 40 to 20, we're hyperventilating. So breathing more rapidly, blowing off more CO2, and pH should return back to 7.4. Okay. Metabolic alkalosis is where our pH goes up. We're going from A to E. No change has occurred yet to our PCO2, but what we've seen is a drastic rise in bicarbonate levels. And this could be because we've lost acids from the body due to vomiting, gastric suctioning, certain diuretics, or excess intake of alkaline drugs. You can take like buffers, which is something that sometimes athletes do, trying to prevent lactic acid from messing up their pH. Sorry, I hit the wrong button. So we go from A to E. Bicarb levels are way up, so we compensate by hypoventilating, slowing the loss of CO2. More CO2 in our body combines with water, becoming acidic, and our pH goes back to where it belongs, down from wherever that was at, 7.5 or whatever. And, over here on the right is just an illustration how we can get hydrogen ions out into the tubule lumen So get it out of our body. This is something we talked about earlier in the lecture, and we kind of included it because it's showing you this is taking place in the collecting duct, where we're doing kind of the last minute finalizing of the urine formation. And then over here on the far right, I snagged from a different textbook. Just shows, kind of simply, how can we cause acidosis? Kind of two things: accumulation of acids or loss of base, or a combination of the two. Any pH rise or alkalosis can be caused by a loss of acids and or accumulation of bases. So you can kind of just simply think of it that way. Stuff like this, I'm not going to ask you to know for the exam, but I wanted to walk you through it, just kind of just demonstrate how crazy complicated, but how crazy amazing it is that we are, using our kidneys, using our lungs, and how they're working together to keep our body at that 7.4, getting close to it. Okay, that will wrap us up. So I'll shut her down.